Our first speaker will be Professor Arshad Khaleel from UK. He will speak about a very important topic, non-union, why me? Professor Arshad, would you please start, sir?
Is that working, sir?
Yes, sir.
It's always amazing when it works. Sorry, I have. Okay. So I was asked to talk about non-union, and actually I wasn't. I was asked to talk about, give a topic, a title for my topics, and I chose this because the problem with non-union is this could be the patient.
Sorry, Mr. Khaleel, we can see the presenter view. It's not full screen for us.
Oh, I'm so sorry.
No,
let me correct this. How do I do this now?
I think just stop the sharing and start again. Oh,
yes.
That's it.
Yes.
Is that better?
Now,
okay. Yeah. So, this is that me? No. Okay. So this could be the patient. This could be the surgeon who did the operation, or this could be the new surgeon who's seeing the patient. Because when I saw this, I said, why me? Because this chap is 17 years old. So that's the problem. Now, this is available everywhere. Non-unions are extremely rare. The Scottish evidence shows that they're about less than 2% of fracture fixations, typical male. But the peak incidence, I was surprised, is between 25 and 45. Diabetes increases the risk by 7-fold, and we know the common bones. The problem is about diagnosing non-union. The traditional 3 out of 4 cortices was actually in rabbits, 22 rabbits, and that's where that paper came from. The CT scan, we still don't know what we mean by clefts in bone. Looking at callus, the Rust classification is also available, but more or less we have a working idea of what a non-union is. And the treatment concepts have evolved from the bringing together the soft tissue, bone, and biology, the mechanics and the biology together. And most of these classifications, like the NUS, about how to treat, are best applied retrospectively. Prospective application is available, but we all have a gut feeling of what works and what doesn't. I call non-unions IVOs. Okay. We all blame the injury. Sometimes we blame the manufacturer. We blame bugs. We blame the patient. The patient blames the surgeon. And sometimes we can't find anybody else to blame. So I call them the IVOs. Let's go through my learning. So here is a 47-year-old lady, and I'm not going to say that's a blame, but she smokes. She had a high energy open fracture of the femur. So you can imagine that's pretty violent. She's already had 2 operations, okay, on her femur. And this is her. She's now been dynamized. So that's 3 operations by the time she comes to see us. And you look at that and you say, that should join up, shouldn't it? But it hasn't. 2 years down the road. So one of my colleagues says, right, we can fix this. And this is the traditional method. And I've put this picture with that screw to show that we did use the femoral compression device. And that was done. I personally dislike this implant because it changes the hip offset permanently. But on this occasion, here we go. That's not working. So we now have to do something. Right. We do something, and 5 months after intervention, this happens. So what did we do? It was actually, of all the operations she had had, what we did was incredibly simple. This is all we did. We did not do any open surgery. We just dynamized the plate by taking out all the screws percutaneously. We did not do any open surgery. All we did was correct the mechanical axis of the bone and compressed. Okay, so compression along mechanical axis, no open surgery, and that was the result. So the first lesson that I learned was that mechanical axis restoration and loading along mechanical axis restoration is key. And therefore, once you've learned something, you start to use it elsewhere. So here's a young man who had a sporting accident, and you may think about whatever the surgeon chose to fix his implant. This was in fashion in those days. There's a closed injury that was done, and now he's 6 months later, and it's not working. So we do our operation, and 4 months later, this happens. And what did we do? Again, no open surgery, just dynamize the nail, and we did compression along mechanical axis of the humerus. So you have to find the mechanical axis from there to there, identify it, and the frame goes orthogonal to that. No open surgery. Where we learned about mechanical axis restoration was from our trauma experience. So here is a young lady or middle-aged lady who's come off her bike, and she's, as you can see, quite a nasty proximal tibial plateau fracture. And that is the result after treatment. What was amazing was the lack of external callus, right? We are not using rigid fixation. We are using wires. So in those days, my frames were not even hybrid. They were all wire constructs. So we've used an all wire construct, and what we notice is no callus whatsoever because we restore the mechanical axis. And you'd think if it works in one periarticular fracture, what about this nasty piece of work? And there you go. So you see a little more callus. With mechanical axis down the ankle becomes a little difficult, but you'd still think that that is a pretty amazing result. And we wrote this up, our learning, and we shared our experience. But if you think that is what we discovered, no, that's not true. This was discovered ages ago by very clever people, because we all have seen this, that if we distract bone along the mechanical axis, we don't see callus, do we? So, and we are all used to seeing this. Okay, but just when you think that you can solve all problems with one method, you learn this. So this patient has gone on to a non-union. The mechanical axis is still maintained. Why did that happen? Or how does malunion happen? So clearly mechanical axis is important, but it isn't everything. So now we have to go and reflect. So now I bring on my case 2, which made me think. So this is a lady who has rheumatoid arthritis. Okay, and she is on rheumatoid drugs, and if she doesn't take them, she's crippled. So she has to take her drugs. She already has established knee arthritis, and she has a simple or low energy fracture of her tibia. She's already had one operation, and this is it. And now she has dynamized her nail again herself. So you'd look at that and you say, oh, this is bad luck, isn't it? This must be the rheumatoid. That is, mechanical axis is not bad. Okay, she's got an arthritic joint, but it's still supple. So it must be the rheumatoid arthritis that is doing it. Okay, so we take out the nail and we compress along the mechanical axis, and we think, this should work. And look, it's working. About 6 months later, this looks very encouraging, doesn't it? So what we do is when we think that the patient's frame is joined, because we don't have patients like elsewhere, our patients are outpatients, what we do is in clinic, we take out these rods across the non-union or the fracture, and we make the patient walk for a couple of weeks. Okay, and if they don't get pain or deformity, we call it union. And we call it staged dynamization. So when this patient then underwent staged dynamization, you can see already that the frame is beginning to kink. So this was worrying. We took it to theater, and guess what? She hasn't joined up. So just by restoring mechanical access on this occasion, we couldn't make her bone knit. So we had to go and do some homework. What we noticed were these diaphyseal fractures were at an oblique plane, a plane of around about 50 to 60 degrees, depending on how you measured it. So the traditional method of fixing these were either this method or that method, and that's the method I'd used in this patient. The Italians had and the Russians had tried this method, okay? But we thought, what about using compression screws? Now, the problem with compression screws is we see that screws in nails break. So clearly that isn't the answer. We need something that is able to self-tension. And therefore, what about this method? And we subjected this to a fracture using gauges, and we measured the strain across the shear plane. And look, these are all these other methods that we've been using, which give you a strain rate of, percentages, whereas the locked, when physiological loading, reduces the strain rate dramatically. So this was fantastic learning. So guess what we did? And what I can't believe is how come I didn't know this already? Because look, Powell's in 1960 and Perrin had already worked this out, that if you control the local strain rate, you affect bone response. Okay. And where does that internal shear happen? It's actually in the collagen fibers. It's not in the brittle material of bone. It's actually sensed by collagen fibers, and then therefore the mineralization is affected. Okay, so here's the same lady. I then said, right, I think I now know what I should do. So apart from mechanical access, we now control the local shear, right? And look, guess what? Even though she was taking rheumatoid drugs, 4 months later, this happened. I still did not believe it. So this is stage dynamization, where we take out all the struts across the non-union. And this is what shear wires look like. And she joined up. Okay. And we then applied this, because it was done in basic sciences, we then applied it to a whole bunch of in clinical practice, and we continue to do so. Eventually, she also had her knee replacement. So we learned about mechanical access, but we also learned about local mechanical environment, in particular, local shear in diaphyseal bone. Right. Now let's look at this chap. So this young man had was involved in a road traffic accident in a motorbike and had an open distal fracture. He at the local hospital, he underwent a staged protocol, because that is what the current method of treatment is, which is to stabilize till the soft tissues have healed or the plastic surgeons have had a go, and then mini internal fixation, or MIS internal fixation. So this is him. He had an open fracture, and a few weeks later, when the soft tissues had settled, he had this at his hospital. Now you may criticize the fixation. I don't have a problem, but so this is him, and this is him 6 months later. There's no infection, but it's just not healing. He's working on it, but it's not healing. Okay, so we do a CT scan, and what we notice is this. Okay, and if you open this, especially in the distal third of the tibia, and sometimes in the proximal third of the tibia, I call this a bleached coral. Okay, so if you open, you find that this bone is just not bleeding. The canal is closed. That bone is not bleeding. It almost looks like, because I grow coral at home, and when they die, you can actually see what that looks like. It's almost like bleached coral, dead coral. So I call it coralization of bone. Okay, so that made us go look at a few things. We looked at our anatomy books, and if you look at the distal tibia lower down, this is what we see. it's white. It's white because there is no muscle attachment, which means that this part of the bone gets its blood supply mainly through intraosseous. So if you have a significant fracture and then you end up stripping the soft tissue either through surgery or through injury, guess what the risk is? Okay. And then I did something else. I got my radiologist and I gave him a hard time. I asked him to measure the volume of bone versus the total area of the leg at 3 centimeters and 5 centimeters from the joints at the top and bottom. And what we noticed was this dramatic change in the volume occupied by bone rather than bone and soft tissue. Okay, almost doubling of the volume of bone in that area. So you can imagine what happens if you end up putting 2 plates, even though you put them MIS. You can imagine the effect of that in terms of the volume of soft tissue to the whole volume of leg. So this chap we treated by bifocal method. You have to get rid of the bone that's coralized and open the medullary canal and do proximal osteotomy. And this is him joined up afterwards. Okay, so what we learned, the third lesson, is when we look at fresh injuries, we have to consider risk. Okay, so the biggest challenge I find in non-unions, having done one this today, is this type of problem where the joint is lost. So the talus, unfortunately, in this patient has no cartilage, the tibia has no cartilage, and therefore this non-union cannot be treated simply by bone surgery, and we have to fuse the joint. An ankle fusion with in non-union is probably one of the biggest challenges because you have a whole bunch of the foot itself is a completely different piece of machine, and we have to get that right. And where to position the talus in relation to the tibia. So I use the anterior margin and make sure that I can see Neary's line. I must see the subtalar joint on the lateral to be sure that I've got the foot correct. And this is the gentleman afterwards. So this still remains one of my big challenges. But the most important thing about non-union is preventing them. Okay, so now that we are armed with knowledge, here is a patient that I treated. We treated recently. So this is a young lady involved in a road traffic accident. She has a closed proximal tibia and fibula fracture. Okay, with comminution. So let's talk through our surgical planning for her. What are her problems? Well, there's a loss of mechanical access. Okay, we can see that there's a kink. The fracture is periarticular. There is a shear plane. Okay, and this is reasonable violence to the bone. So there is a reasonable soft tissue in a component to this injury. So having thought of all these things, we correct the mechanical axis very simply. We correct the shear plane. And on this side, we did not want to leave any wires outside because she had blisters on the skin. So the olives were cut. So the shear plane has been neutralized. And look, that is the sum total. So we have used 1, 2, 3, 4, 5, 6 screws, the plate spanning a couple of plates on outside and 6 lock screws to treat this this fracture. So we have a very low surgical footprint, and that's her at 6 months. So usually I'm asked about my choice of bone graft in non-union surgery. Well, when I was learning, and my boss used to use bone graft. Mr. Simonis taught me this technique of using the Nicole tricortical graft, especially in forearm bones, where you can use it for primary compression. So yes, we use tricortical graft, and I had to, when I joined my unit, my colleagues were doing this funny thing, which when you take out, there's no bone left. And therefore, if you don't put a tricortical graft, you produce dramatic transfer metatarsalgia. So we developed this technique of tricortical graft. I think it's industry standard now. There's no big deal. But if we look at cancellous bone, I make my young chaps go and look at cancellous bone. Cancellous bone is basically air. It is one cell thick. It has no blood supply. So if you put cancellous bone graft, you're actually putting dead bone in at a fracture site. Okay, so you may argue it's of its uses, but for me, putting cancellous bone is the only use would be dead space management, temporary dead space management, and for that you might as well just use a bone substitute. If you could make dead bone alive, sir, I think the Egyptian museums would be far more fun. What about platelets? So this is my only foray in biologics, and we use this the GPS platelet separation technique, and we were not sure what effect the GPS had in our union rate because it didn't change it. All we could say with confidence is that it had no side effects. The only thing that I've tried, which I would still like to use, but at the moment, actually now that we are out of EU, I might be able to go back to it, which is this, is an HA coated wire. So I know I was asked to show only 3 cases. I've now sneaked one in. So this young, I think it was a lady, went skiing and had this fracture in France, which was plated. It was actually a closed injury. That's the shocking thing, was a closed injury, and this was done to her. Anyway, by the time she came back, it was obvious that that was infected. So we had to excise dead bone and do bone transport. The point here was that, yes, when you do bone transport, you get primary bone healing up there, but you get secondary bone, cartilaginous bone healing here, as Professor Elizarov and everybody else has shown. So once you dock, you now have to do something else. I think the fundamental problem is by the time docking happens, the wires have gone through their plastic, they have plastically deformed. So they're not actually producing any compression. However, at that age, I did not know that I could nail this. Nowadays, I would just nail this without a hesitation. But we had got to this stage, and now we're watching this. And then we got fed up. And it's still not joining up. So what I did was we had these we got HA coated wires made in the EU. And all we did was run an HA coated wire. And within 6 weeks, look, we've completely dynamized that frame, and it's solid union within 6 weeks. Okay, and we had another situation where we had to do an ankle fusion, and the ankle fusion was successful. Can you imagine? We've got successful ankle fusion, but the proximal regenerate still looks like that. Okay, you say that maybe the frame is stiff, and that's why it's not producing bone normally. But you can't keep looking at it and do nothing. So we put an HA wire, and from the time of surgery to 6 weeks, that's what it's looking like. So that was fantastic. And I think this is what happens. This is, you have a supercooled situation, supersaturated situation, and all you require to produce crystallization is this. And that's probably how I would explain how this phenomena works. And we used it in a bunch of patients. The problem we had was this was manufactured. The company moved to Turkey, and Turkey was outside EU, and therefore they couldn't get their CE mark. But now that we are out of EU, I might be able to source my HA wires again. And I showed you this gentleman, and I said, why me? And that day I felt very sorry for myself. So this is a 17-year-old, and he's now 6 months. This is not infected, and that's the problem. So I met him just before a couple of years ago. I think he came, and that's him. And if this works, by now he was 17, and now he is married and he has a child. Thank you.
Thank you so much, Professor Arshad Khaleel, for this very illustrative and very important talk. Thank you so much, sir. Now we will move to the second